Okay. We always pray that that works, right? All right, good afternoon, everybody. As Rocky said, my name is John Lloyd. Before I get started, a little housekeeping that I want to do. Is everybody here from the Public Defender's Office? Yes. Yeah, so there's no prosecutors, law enforcement, DCF. No. I'm going to pass this around. I'm going to ask if you just put your email address on, because I'd like to send a copy of this handout to everybody. I don't know how many people would be here, and it's fairly lengthy. I want to go through printing it all. Everybody prefers electronic these days, so I can send it out to everybody. You'll have a copy of the handout. I'm also going to take and pass around my cards, so you'll all have my information. One more thing, my colleague back there, Dr. Joseph Gutman, is helping me out today. Dr. Gutman is an MD. He has retired from practice now. He works with me in research, so he's a research physician, and I'm sure that he would be glad to answer any questions or assist in any way as well. So, this presentation is about the biomechanics of pediatric brain injury. I want to give you a synopsis, if you will, on what we know about the mechanical causation of brain injuries in young children, and how can we work together to prevent these kind of injuries. What I mean by working together is, imagine in a larger group. I've had larger groups in the past that have included DCF, law enforcement, prosecutors, and so it's a large team where people are coming at it from different angles, and there's a lot that we can learn, not just in terms of the medical legal ramifications of these types of injuries, but how do we prevent these types of injuries in the first place? So who am I? I'm not an MD. They don't let me do this to live patients. This person was dead and had been dead for a long time before they let me get my hands on them. I have a PhD in ergonomics with a specialization in biomechanics from Loughborough University in England. I currently co-director with Dr. Gutman of the Traumatic Brain Injury Research Lab at the James A. Haley Veterans Hospital. I also have an appointment in the College of Engineering at USF, and an appointment that is in process with the College of Medicine at USF. I've written extensively, published 24 peer-reviewed journal articles, 4 book chapters, and presented probably over about 70 times at this point. As I mentioned, I'm a biomechanist. What does that mean? Biomechanics is the application of mechanical principles to biological systems. That's what the definition means. It's not something that's taught in medical school. And there was actually a decision came down from an appellate judge, I think appellate Judge Henry, 1st District, Florida, last year, a case that I was involved with, Florida versus Council, C-O-U-N-C-I-L, in which the appellate court determined that biomechanist is actually the person who is most qualified to determine if there is a mechanical causation of injury. Oftentimes you'll get various medical doctors from various disciplines, neurosurgery, neurology, pediatrics, and they're offering opinion, but they don't have an academic qualification on which to base that opinion. I don't want to be overly blunt, but sometimes they don't know the difference between Isaac Newton and a fig Newton. Because if they did, they would still believe what children believe. Jack and Jill went up the hill to fetch a pail of water. Jack fell down and broke his crown. Short falls do cause head injuries. Not everything is intentional. Now, don't get me wrong, there are real cases of abuse, and we all understand that there are real cases of abuse. But not every case is intentional. There are many cases of accidental trauma, and what's not understood is how much force is generated by accidental means. I've already gone through this, so I'll actually skip. So, by way of a preview, and you'll have a better grasp of this by the time I get to the end of my lecture. So this was a photograph taken, fatal fall, Jimmy Doyle, at the hands of Ray Robinson. Jimmy was punched by Ray and fell to the mat. He that was his last photograph as a living individual. A boxer can typically generate about 600 pounds of force with a punch. That's about 1/5 of the amount of force you would get if you just fall over. So if you actually just fall over, you're going to generate 5 times more force, your head impacting the ground. And if somebody who's trained to do so punched you. And yet so many of these cases we hear, you know, the defendant slapped or hit or whatever. It's like, they see prosecutors and law enforcement personnel, they see the aggression, an aggressive act, and they think it's forceful. They're not the same thing. Force and aggression are not the same thing. You can actually generate a tremendous amount of force by what would appear to be a relatively innocuous event, and that being just falling over. And we'll go through a little bit of that today. What happens is, when somebody falls over, the act of falling over, you have a massive amount of deceleration. Imagine you put I'm not picking on you, Joe. You put a Porsche and a Prius side by side, and they can, obviously the Porsche is going to out-accelerate the Prius, but they hit a brick wall and they're both going to decelerate at the same rate. It's the deceleration that causes the massive amounts of injury. Okay, so in the case of the box, it was the deceleration upon impact with the floor. So my lecture today is going to be in 3 parts. I'm going to talk about the myths underlying brain and brain trauma, the mechanics of brain injury, and causation of injury. So let's go through some of the myths. I think I have 5 to share with you. Myth number 1. It's claimed that the infant brain is different from the adult brain. Biomechanically, there's no difference between an infant brain and an adult brain. The only difference is mass. We'll come to this. Secondly, brain doesn't bounce around inside of the head. We're not Homer Simpson with a little brain inside of a big head. The brain is not floating in fluid. We think I think we're led to believe that this little brain sitting in a big bucket of fluid. That's not the case. It's a myth that short falls are harmless, are not harmless. Excuse me. And I'll show you some of the research that we've done that actually proves that short falls can be very harmful. And you may have heard in some cases that is proposed by board-certified child abuse pediatricians and such, that to fall from a multi-story building or a severe motor vehicle accident would actually be required to cause these type of injuries. Again, a myth. So, infant brain is actually biomechanically very similar to an adult brain. In fact, when we're born, our brain mass is about 400 grams, which is just a little bit less than 1 pound. You can imagine the mass of a newborn baby is about 7.5 pounds, and the brain, just the brain alone, not talking about the whole head, just the brain is 1 pound. That's a huge organ for such a newborn baby. When we are fully developed into adulthood, the brain weighs 1,300 to 1,400 grams, about 3 pounds. So, this little baby's gone from 7 pounds to, in my case, 150 pounds. 20 times increase, 30 times increase, and the brain has only increased 3 times in terms of its mass, from 1 pound to 3 pounds. The application of physics to the brain is the same, independent of all of the other neuroanatomical differences that there may be in child versus adult brain. So the application is the same. We use the same formula, Newton's second law, force equals mass times acceleration. Applies equally to both. Of course, because the child's brain is 1/3 the size, it comes out with a different number, but biomechanically we treat them the same. As I mentioned, the brain does in fact fill the entire intracranial space, at least in most cases. Here's another image for you, talking about the brain floating in fluid. There's actually a very thin film of fluid that surrounds the brain, and most of the fluid, which is called cerebrospinal fluid, is actually in the middle, in an area called the ventricles. And it might surprise you to learn that in adulthood, the amount of fluid in the intracranial cavity is about 1/3 of a can of soda. That's it. There's no spaces, there's no oxygen, there's no air. There is oxygen, the oxygen's in the blood vessels. There's no air pockets or anything like that. This whole intracranial cavity is filled, mostly with brain. The head grows in response to brain growth. There's a relatively very small amount of fluid, and most of it, as I say, is in the middle. A good analogy, and I've been able to use this in the past in court, is an egg. You take an egg, and the egg is completely filled with yolk and the fluid in which the yolk sits. And you can take that and you can shake the heck out of it, and I promise you won't break that yolk. The reason is because that space is completely filled, and the density of the two different materials is relatively similar. So it doesn't matter how hard you shake it, they're not separated. And they're not going anywhere because there's nowhere for them to go. We also talked about short falls. This is a brief video. I'll turn up my audio here. But this is a video from a research study that I did about 10 years ago with the VA. Give you a little background. This study was, the FDA, Federal Drug Administration, was brought in a rule that the use of bedside rails would be considered a physical restraint, and therefore would require a prescription from the attending physician. So they came to me in my lab and they said, what happens if a patient falls out of bed? What's their risk of serious head trauma? So we did a study. This was with a biofidelic crash test dummy. And this was a dummy just falling off of a 3-foot bed. You can see, just feet first as if they were trying to get out. So we did our calculations, and that's 3 feet. There was a 25% chance of a fatal brain injury as a fall from 3 feet. And then myth number 5, we talked about fall from a multi-story building being required to cause types of injuries that we see, devastating, neurologically devastating some of these children. So I did the math, calculated the peak linear acceleration, the peak impact velocity as a result of a fall from height, and you can actually see a fall from a 3rd-story building can generate 60 miles an hour of impact velocity and 280 Gs. Not only would that be neurologically devastating for an infant, but I guarantee you it would probably kill every one of us in this room too. So, yes, a fall from a multi-story building can be highly catastrophic, but it doesn't take that much. This here, you'll see that it's not a linear curve, a linear equation. So you'll see here, this is 1 story, and the velocity from less than 1/2 of 1 story, which is probably around 4 feet, is 20 miles an hour of impact, velocity on impact. So you generate a huge amount of velocity. And then it all depends on what the impact surface is. The harder it is, the less forgiving it is. And you know, in my research I found that wood is a lot more forgiving than concrete, which makes sense. So it falls onto hard surfaces that cause these devastating brain injuries. So let's talk about some of the mechanical properties of the brain that are very important. Brain is incompressible, meaning that it's highly resistant to any change in its size, yet it's relatively deformable. There's no bone inside of the brain, and as an organ, as a soft tissue organ, it can be it's highly deformable. It's heterogeneous, which means that there are different properties within different parts of the brain. You may have heard of gray matter, white matter, brain stem, things like that. So different parts of the brain respond differently to mechanical trauma. And it's anisotropic, which means that it also has different properties in different directions. So, you know, already we've got like 3 or 4 different dimensions of properties here. So it becomes highly complex. And it's viscoelastic, which means it's a time-dependent behavior. I'm going to go through each of these. So, like fluid, the brain is highly incompressible. The density of the brain actually is similar to the density of salt water. And if you put salt water or Tylenol into a syringe, and you put your thumb over the end and you squeeze it, you can't compress that anymore. The fluid is incompressible, much like the brain matter. But like Jello, it's highly deformable. So you've got an incompressible organ that can easily be deformed. And like Play-Doh, it's got viscoelasticity, which means if you grab that tissue or that Play-Doh and you pull it apart slowly, it'll stretch and stretch and stretch. But if you grab the Play-Doh and you pull it quickly, it's going to snap. The same thing with the brain. If you have a trauma that acts on the brain over a longer duration, it's going to stretch and forgive. But if that trauma acts over a very short duration of time, it's going to fail. And then we talked about different directions and different regions of the brain. I don't have any pretty graphics to show that. Let's talk about the mechanics of brain trauma now. There's 2 different ways that the brain becomes injured. The first is called impact loading, which, as the name suggests, has everything to do with impact. So when you have an impact, that causes focal injury. For example, if you fall and you hit your head, or better example, somebody comes at you with a hammer, strikes you with a hammer, that's impact loading. Okay? It's going to cause an injury right at the area where you've been impacted. It's going to cause potentially bumps and bruises, and depending upon the amount of force, it could also cause a fracture to the skull. So that's impact loading. The other type of loading of the brain, or mechanism of injury to the brain, is called impulse loading. Impulse loading causes diffuse injury. So it causes injury throughout the brain. For example, if somebody were in a motor vehicle accident and say they were rear-ended and they got that whiplash, the head doesn't actually need to make contact with anything, but you can have a loss of consciousness, which is trauma to the brain, as a result of that diffuse brain injury. The impulse acting on the brain, the rotational inertia from the head moving and the brain moving somewhat independently inside, and as we talked about, it becomes deformed inside of the skull, and that's what is this impulse loading that acts on the brain, and diffusely meaning throughout the brain. And that is where we get concussion, axonal injury and bridging vein rupture. I don't want to get too medical, but when you have these hemorrhages inside of the brain, those tend to be a result of the impulse loading to the brain. They're not, while they're two different mechanisms of injury, they're not, they go hand in hand, would be a better way to explain. They go hand in hand. So whenever you have a mechanical insult, accidental or intentional, whatever it might be, you will have both impact and impulse components. Only really in a purely theoretical situation would you have 100% impact without impulse or 100% impulse without impact. You're going to have some blending of the two. For example, in boxing, if you've got a boxer, they're jabbing their opponent in the nose, you know, that's mostly an impact because the force is being transmitted directly through the center of mass of the brain. There's very little rotational component to that type of loading. So you're probably going to have, I'm guessing now, 90% impact loading with a 10% impulse loading component. Whereas, as the great Muhammad Ali learned, if you cause the head to rotate, you go, you know, the upper jab to the chin, and the head quickly snaps around on the neck. Now you're generating a massive rotational inertia, and you have a primary impulse loading component, and that's how we figured out you could knock his opponent out and give him a loss of consciousness, because they have a primarily impulse loading to the brain, not impact loading. So this is a picture of rams that, you know, they're well designed to withstand these multiple impact loading. Actually, I've already talked about all of this with them. This is the impulse loading, the brain deforming inside of the skull due to the rotational acceleration, where because of the heterogeneity of the brain, there are different regions of the brain responding differently to that impulse loading at different times, which can cause bridging vein rupture. This is a quick picture of some bridging veins. So these are the blood vessels that return the blood from the brain to the heart after it's fed the organ with oxygen and metabolic requirements. Ahead of myself. So, this is getting a little bit more complex now in terms of how the brain may move inside of the intracranial cavity. There are various protections within the skull designed to protect the brain from this type of motion. We have, back here, this is called the tentorial shelf, and is part of the dura, which separates the main part of the brain here from the cerebellum. And between that and the shelf in the front of the head, that tends to give us a lot of protection in the forward and backward type of brain motion. And then in the middle of the brain, here, between the two halves of the brain, there's a section called the falx, which can protect the brain from side-to-side motion. But in many of the cases of pediatric brain trauma that we see, we have, medically, there are a number of, there are a few issues that seem to be common, and those are changes in heart rate, which is called bradycardia, and reduction in respiration rate, and affecting the thermoregulation of the body, and also changing in terms of the acidity that's measured in the blood. And all of that is controlled right here in the middle of the brain. And the reason I want to bring that to your attention is because, as we talked about, the brain being an organ with no bones in it, as you get closer and closer towards the middle of that organ, you're going to get more and more rotational inertia acting upon those nerve cells, those axons. And so that's why it's important. So, yeah, as I said, as we get closer and closer toward the center, you get more and more rotational inertia. We get this, like a hurricane. The velocity increases towards the center. So, as I was saying before, you have both parts. You have forces associated with impact loading, which is right here, which is normal, and forces associated with the rotational inertia, which are shear forces. And you've got different types of activities cause different types of forces. We talked about where you've got the jab causes a primarily impact loading, which would be the normal forces, whereas that rotation causes the angular forces, which are shear. I'm going to move ahead to some particular experiments that I have been involved with that I find I think are particularly interesting, and I hope that you'll find them the same. The first study I did was a study of kinematics of head motion in an infant compared with what we call pediatric activities of daily living. Second one I'm going to go through with you briefly is shaken impact syndrome. Thirdly, short falls, household short falls. And finally, biomechanics of retinal hemorrhages. And as I do that, I'm going to introduce you to my co-presenter, Krabby. So I'm going to pass Krabby around. Krabby is a biofidelic mannequin representative of a 1-year-old human infant. He weighs 22 pounds or 10 kilograms and stands almost 30 inches tall. He was developed by a special committee of the Society of Automotive Engineers for use in airbag testing, but he's been used in a number of studies now for evaluating the biomechanics of trauma in infants. So in this particular study, we had 3 infant surrogates, if you will. Krabby was one. The second was a demonstration doll, right here, which was from an organization, the National Center on Shaken Baby Syndrome. And by comparison, this demonstration doll weighs only 2 pounds. And then we also had my son, with my wife's consent. He, at the time, Kieran, was 7 months old. And so by comparison, he was almost 20 pounds. The mannequin was 22 pounds. And he was a similar height, but you can see his legs are a little bit tucked up underneath him. So, we used sensors placed upon the head and also inside the thorax of the mannequin to measure the motion of the mannequin during various activities. And those activities included shaking. So you'll see me here shaking the demonstration doll. And we did different types of shaking exercises. Vigorous shaking, as well as resuscitative shaking. Sometimes you hear about, the child was struggling, so they pick the child up, they shake it just to try to get a response out of the child, try to startle the child into a response. So it also looked at that, which we call resuscitative shaking. And then this was one of my graduate students here. She was bouncing crabby on her knee as one of the pediatric activities of daily living. So this is a video of me, high-speed video, thank you, of me shaking crabby as hard as I can. You'll see the head bouncing back and forth. There were actually 9 adults involved in this study, a scientific study. We got it published in the Journal of Forensic Biomechanics as a peer-reviewed article. So there are 9 of us, and we measured how much the head moved and the speed with which the head moved, and more importantly, the acceleration, because that acceleration, that rotational inertia, we talked about that can cause these devastating injuries, and we needed to see where that sat on the threshold scale of injury. And then, my son, Kieran, this was his toy. What happened was, originally this wasn't going to be part of the study, but one day he was in his bouncer and he wanted some attention. So I grabbed my laptop and I sit in there and I was working on this data, and he's just going crazy in his bouncer. So we put a sensor on the back of his head and record him bouncing away in his jumperoo. So this is Kieran at 7 months.
Whoa!
He loved that thing. I'm going to play this at his wedding, I swear. So he would do this for hours on end, and I'm measuring the head motion in all. Yeah, you can see the sensor. This is the wires over here. So he would do that for hours on end, and we're measuring the head motion in all 3 directions. So this coming down to the results of shaking. As I said, we had the crabby mannequin and the doll. It didn't shake my son. We show here, this is angular acceleration. Don't worry so much about these fancy units over here by mathematicians, but the numbers of 1,000 to 1,600 basically is what we get as a result of vigorous shaking. By comparison, 950. So if the other was 1,000 to 1,600, and I've got 950 angular acceleration just from my son bouncing up and down in his jumperoo. Comparing that to some of the other studies that have been done, this is my study. Another study in 1987, and Christine Duhame, she's got similar numbers. Michael Prang, he took a doll and he did various modifications to it, put a long neck and a big head, tried all different types of things just to see how far can we push this, how much angular acceleration can we in fact generate, and he was getting about twice as much as everybody else. Nicole Ibrahim, she had something that was more representative of like a 2 or 3 month old with still having the sutures in the different parts of the brain. She was with having something so small, she was actually only able to generate about half the amount of the angular acceleration that we were. But now let's look at this and compare it to known thresholds of injury. Again, these are the numbers from my research. 1,000 to 1,600 for vigorous shaking, 950 for my son going crazy in his jumperoo. And then these are 4 studies that were done to look at just how much angular acceleration does it take to cause a rupture of a bridging vein. And we talked about the bridging veins. So of course when you rupture a bridging vein, they leak. You know, you get the blood pouring out, and that's what causes the subdural hematoma. So these studies show an average of 8,000 radians per second squared. Again, ignore the units, but 8,000 compared to 1,000 is what we're able to generate, or 1/8 of the necessary angular acceleration to cause these types of brain injuries in children. And as I pointed out before, I'm going to go step back here. All of these studies are also well below the threshold of what it would take to cause bridging vein rupture in an infant, based upon all those biomechanical studies. So we concluded shaking of an infant, you know, while it would be ill-advised, and when I'm asked, you know, why didn't I shake my own son, I tell them I don't think it's appropriate to shake a child, and I feel that, you know, could cause damage to the emotional bond, you know, between myself and my son. Yet, biomechanically, as far as I'm concerned, it produces, as far as the data is concerned, produces head motions that are far below the levels required to cause any kind of brain injury. And the head motion that we got with vigorous shaking was biomechanically, statistically identical to my son bouncing up and down in his jumperoo. And as we said, you know, he didn't just do this once. He did this 3 times a second for hours and hours a day, day after day. I can still hear that thing bounce. Probably the most important thing is, when it comes to these cases of shaken baby syndrome, this is the first study where we have a live human infant being exposed to the forces of shaking acting on his brain, and of course he suffered no ill effects as a result of that exposure. So we have the first human data proving that the forces of shaking do not cause injury. Sometimes it is proposed that a child may have been injured as a result of shaking impact syndrome. So, conducted a study. There were 2 male subjects. I was one. Crabby 12, whom you met. And we considered shaking impact. For this study, we looked at impacts into 3 different surfaces. The crib mattress, a changing table pad, which is the relatively thin pad, and you put a little cover over it that can be washed, and that's what's used for when you're changing a child. And a wooden tabletop, something like a kitchen tabletop, and everything was at about 37 inches, which is a regular table height. And then we tested 3 different ways: gently, moderate impact, and vigorous impact for each of those surfaces. And between the 2 of us, we did this 230 times. So we had a lot of data. And here I have a video of me demonstrating these. This is on the changing table pad. And first of all, that's gentle impact, as you might see. Secondly, a moderate, shaking with a moderate impact onto the changing table pad. And thirdly, a vigorous impact, hitting as hard as I could. Okay, and while this is going on inside of Crowdy's head, I've got all kinds of instrumentation that I'm using to measure the linear and the angular components. Now, kind of missed a step there, but these linear and angular components relate to impact and impulse loading. Okay, we talked about impact being straight on and the impulse being the rotational. And then these are the numbers that we get. There are thresholds of injury for both skull fracture in an infant and brain injury in an infant. For skull fracture in a 6-month-old, it takes about 50 Gs. 1 G is acceleration due to gravity. It takes about 50 Gs to cause a skull fracture. And I'll just, if you'll allow me, I'll go off on a little tangent here. There was a study done in Germany, 1984, Dr. Weber. He took 15 infant human cadavers and he dropped them from changing table height, which was 32 inches, onto different flooring surfaces, and which was changing table height, probably about the height of my table here, 32 inches. From 32 inches with 15 human cadavers, he produced skull fractures in every case. Every case. So when when we're told by medical doctors and detectives that, this person must have, handled this child, they're so vulnerable for that first 2 years of life that a short fall from here to the ground can cause a devastating skull fracture. That's all it takes. And it's been proven, not once, but in every single infant that Dr. Weber tested. So we know that it takes only 50 Gs of linear impact acceleration to cause skull fracture in a 6-month-old. By the time they get to 1-year-old, it takes about 80 to 100 Gs. So by 1-year-old, the skull is much more formed, and by 2 years old, the sutures tend to be well formed, and the skull is getting much stronger and on the way toward the skull fracture threshold for adults, which is 250 Gs. And then we talked a little bit about already the failure threshold of the bridging veins and how that relates to subdural hematoma and bleeding in the brain, being about 8,000. So what I did here was highlight the only 2 cases where we had exceeded that 8,000 threshold for brain injury. And you'll see in both of these cases, we've also exceeded the threshold for skull fracture. So the conclusion that brings me to is that if we have a case of shaking impact where somebody has purposefully shaken and or impacted that child on something hard, we would expect to see both brain injury and skull fracture. Okay? Because so many times where you have one without the other. And the research shows that we would expect to see both. And the reason for that is because I was explaining before, the way that the skull is designed, and you've got this shelf that supports the back of the brain, you've got the shelf that supports the front of the brain. The skull and the design of it does a very good job of protecting the brain in that forward-backward plane, which we call anterior-posterior. And that's also the direction in which the force tends to be directed when somebody is doing a purposeful or intentional impact act. So, let's say I would expect to find both brain injury and skull fracture. And then, this is going on to the 3rd study I wanted to share with you. The biomechanics of short household falls. I've been involved in a number of cases where children have experienced a short fall. There was one, not in this district, but further north where a child was climbing up on a table in the kitchen, slipped and fell, and suffered a neurologically devastating brain injury. So that's the kind of cases that this type of research looks to investigate or evaluate. So the way I do that, I say inside of Krabby's head, I put all of this instrumentation to measure the linear and the angular components, and then I've constructed this table. I call it a gallows, because what happens is these two electromagnets, they release the table, and it opens, and the Krabby can fall out onto different flooring surfaces. So I've looked at different types of falls, whether it be a supine fall, a seated fall, such as a child in a seated position on a bed, falls from a seated position, or maybe the child rolls off the bed, and how those different types of falls generate different types of characteristics in terms of the head motion. Looking at also different flooring surfaces, wood, linoleum, carpet. Published on this. Carpet is pretty, and it does a great job of collecting dust, but in terms of protection from a fall, it's pretty useless. Wood is actually the best for protecting, surprisingly, because the wood has got a lot of give to it. A lot of give. And I've studied, fall heights from 0.5 to 2 meters. Here's an example. This one, the Krabby is up here. This is a high-speed video. The trap doors are going to open with the aid of electromagnets. So I shut off the power to the magnets. The trap doors spring open, and then the mannequin will fall. And in this case, I think I have a carpeted floor surface down here on top of a force plate that I can use to measure the impact force. And let's run. There we go. So you'll see, that Krabby bounced with that impact. I'm going to play it again. Play it. Okay, I'll replay that. So, and that would represent a child maybe falling from parents' arms, something like that. That kind of height, 3 to 4 feet. So, the results that I've been able to gather through this type of research is that it takes a rolling fall of only 21 inches, sometimes even less, to produce angular accelerations that would be indicative or sufficient to cause bridging vein rupture, subdural hematoma in a young infant. In fact, changing, as we talked about with Dr. Weber's research, fall from a changing table is more than sufficient to cause skull fractures in every case. And that's onto a carpeted or tile floor. And then lastly, I'm going to bring in, I'm going to talk a little bit about biomechanics of retinal hemorrhages. Because this is, I find that through many of the cases that I'm involved with, this is kind of like the cornerstone of these cases is retinal hemorrhages. The ophthalmologists are brought in to do these evaluations, and what they do is they look through the pupil of the eye. They look at the retina, which is back here. This is kind of like the projection screen of the eye. They look back here, and they're looking for hemorrhages in the retina. A hemorrhage is nothing more than a little bit of blood that leaked, all right, or a bruise. Whenever you ever have a bruise, that's a hemorrhage. That's all it is. Okay, so there are different theories proposed as to what it takes to cause a hemorrhage, and some of those are that when you're shaking a child, you've got all of these forces acting on the eye, and you have the vitreous humor, which is this part of fluid inside of the eye, pulling against the retina, causing like a suction on the retina. That's a theory that's been proposed by Dr. Alexander Levin, for example. But it makes absolutely no biomechanical sense, because the density of the retina and the density of the vitreous humor are about the same. And they're all the way up here in the eye. If my point of rotation is in the neck and I'm doing this, I'm not going to cause any effect up here between two matters of similar density. It's just not going to happen. What does make a whole lot more sense is something called, well, actually that's Alexander Levin's was the vitreous traction. Venous occlusion makes a whole lot more sense. What we have here is, this is where the optic nerve comes into the eye. And this is the dura. The dura is the same skin, if you will, that's over the brain, underneath the skull, but over the brain. It's called the dura. And it's the same material that goes into the eye. So whatever's going on inside of the brain is also going on here. Whenever you have an increased pressure inside of the brain, you have an increased pressure here, because it's like a continuum. It's like a lake connected to an ocean. Whatever goes on in one, goes on in the other. They're connected. And through here, we have the optic nerve, along with the blood supply, the artery that feeds the eye, and the vein that returns the blood from the eye. So when you've got pressure, it's kind of like a garden hose. If you've got a thick hose pumping fluid in, and you've got a thin hose with fluid coming out, if you've got enough pressure that shuts down the hose where the fluid is coming out, at the junction between those two, you've got to build up a pressure now at that point. You've got more blood trying to be pumped into the eye and nothing coming out. And you have all these little capillaries in between that burst. And that's all retinal hemorrhages are. And it's also known that the more time that passes that this pressure is acting on the eye and on the brain, the more retinal hemorrhages you're going to see. So there's a number of papers that talk about that, and I can get into that a lot more. But I have this, kind of summarized everything here with this logic table. Kind of boils it all down and simplifies it for me when I'm in terms of looking at the different characteristics of different types of mechanical trauma. So mechanical trauma I'm looking at are shaking without impact, shaking with impact, shortfall, which is impact without shaking, and then medical mimics, medical trauma, if you will, non-mechanical. And here we down the left side, I have external signs of trauma, which is bruises, bumps, skull fracture, which would of course be external, brain injury, like the subdural hematoma, and retinal hemorrhage. And in shaking, without contact, we have none of these. You certainly don't have a skull fracture, you certainly don't have bumps and bruises. We talked about how there's certainly not enough rotational inertia to cause any kind of brain injury, and because there's no increase in the pressure of the brain, we're not going to cause any retinal hemorrhages, which are secondary to the brain injury only. With impact, if you've got an impact, you've got a bruise. If you've got an impact, you could cause a skull fracture. If you're going to have brain injury, you're going to have skull fracture too. These go hand in hand with shaking impact. And because you've got brain injury, you're likely to also produce this retinal hemorrhage. Whereas with a short fall, it's possible to get brain injury without skull fracture. So this is kind of like the big differential here, because oftentimes you'll hear where it's claimed that the person caused this impact. Well, if the child doesn't have a skull fracture and yet does have brain injury, the research says otherwise. And then finally over here, in the mimics, you would have brain injury with no external evidence whatsoever of any kind of mechanical trauma. You don't, I mean, if there's going to be sufficient mechanical trauma to cause a brain injury, so there's got to be a bruise. You can't have that kind of neurologically devastating trauma without leaving a bruise. It takes so little to cause a bruise. And then, putting some of my research into context of others on a nice graph here. This was my shaking study, and here the black line is the threshold of injury for bridging vein rupture and subdural hematoma. And you'll see how we're way below the levels required to cause these kind of brain injuries, yet a short fall of an infant rolling off the bed or slipping in a bathtub is more than sufficient to cause that amount of brain trauma. And then if we compare it to things like college football impact and concussions in college football, boxing punch, this gives you an idea of where it sits sort of in the realm of things. And then finally, I'm just going to pass this out. It's just something for you to hold on to. I'm not going to go through a full explanation of what this is, but this is kind of where I'm going now in terms of in my thought process. I'm going to be working on a paper on this. This is why I passed it out. It's too cluttered to try to talk you through on the screen, but basically what I've got up here are, this is all about mechanisms of brain trauma in young children. And over here I've got mechanical causes, such as a crush injury, where somebody may fall on a child, or something that I hear a lot of is a television falling off of a table, landing on a child, or maybe the child's trying to climb onto an entertainment center and it's fallen over. That's called a crush injury. And then we've got falls and impacts, secondary impacts, alleged shaking, and then over here I've got some medical causes. But what I'm trying to show here is that they all come together and produce the same ultimate effect, which is starvation of the brain of oxygen and blood, and how that causes swelling, and how that swelling increases the contents, and that increases the pressure, and it leads to pain and retinal hemorrhages, and ultimately to brain cell death. So this is something that I'm working on right now, bringing it all together from the medical side of things, as well as from the biomechanical side of things, to show how these medical conditions and mechanical conditions can all lead to the same ultimate conclusion. So with that, I'm going to end and ask if anybody's got any questions.
Have any prosecutors used you or someone like you, especially in the case where their theory is it's an impact, throw down on the mattress or something like that?
Yes. I'm currently involved in a case up in the Panhandle. I was hired by the prosecutor. It was their opinion that, the prosecutor's opinion, the detective's opinion, that the child was slammed. It was a shaking impact case. I went through all of the information, and it was my determination that it was actually what's called a secondary impact. So these parents, a child was on a bed. They're in a hotel somewhere. The child rolled off the bed and landed on the floor and screamed and all the rest of it. So they put the child back on the bed, and the child rolled off the bed again. Not very smart. But so what we've actually got there is a case of what's called second impact. What happens is, when you've got an impact or any kind of mechanical event in brain trauma, that's just the beginning. because after that first traumatic event, there is set in motion all of this stuff which is called the secondary effects of trauma. There are ionic fluxes that are going on inside of the brain. There are biochemical changes going on inside of the brain. And the brain sort of kind of goes into overdrive and yet starved of oxygen and got decreased cerebral perfusion and all of this. So the brain is kind of in turmoil. And then if you have a second impact during that time while the brain is trying to heal itself, you've got a much greater risk of a very severe outcome. So yes, I've been retained on cases by both the prosecutor and public defender's office. I've also, I worked on cases with the prosecutor where I've said, you know, this I think is an accidental cause, but I've also had cases with the public defender's office where I've said, I think this is an inflicted impact. So, you know, I always, I consider my opinion to be unbiased, and I basically explain what it is that the science says in these cases. Any more questions? Yes, sir?
You talked about how the body is good at protecting back and straight forward and back, shaking. If you shake side to side, is there less protection?
Inside of the skull, between the two sides of the brain, there's something called the falx, which is an extension of the dura. So the dura is this thick membrane over the brain, and it comes down between the two hemispheres, and that's called the falx. And that kind of protects the brain going back and forth and minimizes how much the brain can move back and forth. But there's very little protection of the brain, I think, in terms of what's called axial rotation. So when the head is moving like this, I don't think there's a whole lot to protect in that case. And in the middle, right in the middle of everything, is the areas of the brain that are responsible for breathing and respiration and body temperature regulation and all those critical things. I mean, which makes sense. You put it all in the middle where it's going to have the most amount of protection. But when you have these rotations, the rotational inertia acting on the middle part of the brain is really, you know, I think what leads to these major cardiorespiratory arrest events in these young children. Any more questions? If you have colleagues in other judicial circuits that you think would benefit from me sharing this information, I travel quite a lot with my family, you know, camping quite a lot, so I'd be happy to offer this lecture in different areas too, so please feel free to pass along my name. All right, thank you everybody.